I graduated from medical school in 1987, and I tell you that primarily because this year, 2017, marks 30 years of my being a medical doctor. I don't normally give that information away immediately, but I want to bring it today because I think it really factors in to what we're going to be talking about. I, in 2010, decided that I would quit accepting new Medicare patients into my practice. And at that time, it was many years before I actually opted out of Medicare. But the reason that I did it that way in 2010 was because Medicare, CMS, kept sending me emails of friendly reminders or possibly veiled threats, depending on how you want to look at that, of reminding me that they were going to, in 2015 or 2016, they were going to penalize me if I did not adopt the electronic health record or participate in meaningful use. Well, I had seen, through my 30 years now, I have seen what the electronic health record has done to the doctor's note. It has destroyed the doctor's note. It has taken a very honest and relevant document and turned it into, as we heard moments ago, a dishonest document filled with irrelevancies that the physician, he or herself, has to enter themselves. And I knew that I would never practice that way. So I knew those dates, and I planned for those. I feel like I have to give a little bit of a disclaimer right now, or a point of clarification. Whenever I make the comment to other physicians, wherever I am, if I'm at the FMA or if I am in my local community and I mention that I do not use the EHR, I get a look, kind of, what? And I think what they're thinking is, do you practice in a cave or something? And I don't know, I don't. And I'm going to show you an example of an exam room of mine. So see, I actually have a computer in my exam room, and I use the computer to facilitate my patient interaction and visit. But I do not let the computer interfere with my doctor-patient relationship. And my relationship remains with my patient and not with the computer. And that meant everything to me, including giving up on Medicare, so to speak. But I think as this talk goes on, you'll realize that I did not give up on the Medicare patient. So this is an example of what I'm talking about. It's part of my activation phase. I've gotten more involved in trying to be more active. I would consider myself at one point to have been in a sort of a dormant phase most of my 30 years, but more recently I have become active. And one of those is getting involved in the FMA and doing things of that nature, but also getting on Twitter. I don't know if any of y'all do this, but I think it's a fun place to be, and I think that a lot of patients are looking for doctor information and what the doctors think, and I have fun with it. Okay, so this was a post, and it says, when a picture tells the story, today's doctor-patient relationship. And so I retweeted that with the comment, what a waste of a great profession. So the step one is you have to quit accepting new Medicare referrals. If you're contemplating this as an opt-out, if you haven't already done it, I would recommend going back on Monday and just quit accepting new Medicare referrals into your practice, because it does and helps you to change the milieu of your practice so that you can bring in less Medicare patients and then bring in more private pay or cash pay patients. So I did two things in my preparation for opting out that I think are helpful, but I'm not sure they're absolutely mandatory for any given practice. I set up an annual service fee. It's $35 per patient or $45 for a family, and this covers administrative paperwork type things. It has now been in effect for about 3 years. I initially got a little bit of pushback on it. Patients were wondering, well, what am I paying for? Why am I paying for this? And once I explained to them what it was, most people gladly, gladly went with it. But I didn't lose any patients over this. And now it is a way of bringing in a little extra income to try to help cover all of the things that we do on a constant basis. So in your packet, I have included the things that I put down as part of this administrative fee. And I literally made a list that listed everything that we do. And if you come up with any others, I'd like to hear it, because I may add it to my list. also did two things which I'll call acknowledgement statements. I did not want to be accused at any time. I knew that my opt-out was coming for 2015 or 2016, and I did not want to be accused at any time of not having warned the patients that my opt-out was coming. So I had them sign acknowledgement statements, and I will say that primarily I'm being made aware. So I acknowledge that I am being made aware that Dr. McKnight chooses not to participate with certain Medicare mandates, including the EHR and meaningful use. And she will be penalized by Medicare for not participating, and those penalties will increase each year. And she will continue to be a Medicare provider as long as it's feasible. And I had the patients initial it. So in the 2 years or so leading up to my opt-out, every single patient signed this or initialed it. I also did a similar one for maintenance of certification. I figured while they were initialing that, they might as well initial this. And basically it said all the things that you see here, that I participate in CME as a way of keeping up to date in my specialty, and that I'm compliant with my Florida State Board of Medicine, all that they require, and I've been licensed in Louisiana and Florida for over 20 years, but that I do not participate in maintenance of certification or time-limited certification exams. And the patient had to initial it. Now, I believe that every doctor in America should have their patients sign something like this, because we could then look at the American Board of Internal Medicine and say to them, we're not going to do your MOC, our patients don't care about it, and that could really have a great effect. I started towards my opt-out, which was ultimately January 1st of 2016. I sent the letter in, as we've been talking about. I wanted mine to arrive at Medicare October 1st, 2015. I really tried to time it that way. I don't know if it did, which would have been the day ICD-10 hit. I wanted someone at Medicare to open up my opt-out letter on that day. I ultimately opted out, as I said, on January 1st. Well, those 3 months in between, once I had sent the letter, I felt pretty obligated that I should at least talk to the patients that came in and tell them what I was doing. So I had a little technique about this, and so I was going to share that with you. What I would do is I would do the whole visit as we always did, a very attentive visit to the patient, all for the patient. And then at the end, I said to them, I said, look, I have something to tell you. I'm going to be opting out of Medicare come January 1st, because Medicare is trying to put me into using the electronic health record, and we would never be able to have the type of office visit that we just had. And it was really quite effective. People understood it. I said I would have to be forced to spending my time looking and staring at the computer, and that I would not be able to have the time where I would be looking at them. I honestly believe that if your patient is describing things like pain, you should be looking at them and not the computer screen. So what I set up was something called what I call fair cash prices. I'm a rheumatologist. We have no cures for any of the disease that we treat. We manage chronic illness. So the goal of this is to incentivize chronically ill patients to be seen on a regular basis in the clinic. It's for established patients, what I'm speaking of here, and it's based on 12-month intervals. So you can do a pay-as-you-go, which is $90 for the first visit, $85, $80, and then $75, and I will see you as many times as you need to be seen for $75 during that 12-month period. Now, my rationale behind this is this. I treat diseases that are chronic, they are prone to flare up. I do not want people out there who are afraid to come in. They're afraid to get in because the price is too high. I want them to have a very low bar to getting in. It makes it easier on me. If people are showing up regularly and getting the care that they need, it is easier for me because I know who they are and I've been managing them, and so hopefully things are going well. And it's better for them because they're getting better care. I have groups of patients who have to see me 4 times a year. That would be methotrexate checks and things like that. So I set up a prepay option, $300, and you can come in 4 visits. Now, if you do not make your visits, 4 visits in 12 months, you will not be refunded because this is, again, incentivizing compliance. Methotrexate patients should be seen 4 times a year. So if you don't make it in, I know we'll reschedule you if there's an issue, but if the 12 months pass, there's not a refund. I also discourage people from staying away too long, and that's why the prices get higher as you go, all the way to then a new patient price, which would be $225. Shots and injections are additional, and patients understand this, and they have no issue with that because they know that the original price they paid was for the doctor visit, and that has value. All patients then pay the $35 service fee. And for the first time in my life, I had to institute a no-show fee. I'd never had that in all of the time that I practiced. And so the reason is because in a cash pay environment, or now even with the high deductible type plans, if the patient is feeling good on any given day, they may not want to come in. And again, I am managing disease, so I need you back so I can see how you're doing. They'll say, well, why do I need to come in if I feel well? Well, let's take coming off a flare, for instance. If they were having a flare, I want them back in so I can make sure that their definition of improvement meets my definition of improvement, and sometimes that's different. We need to follow up on labs and check out that kind of thing that may have been ordered. And then also, at the follow-up visit, I want to be able to then do a lot of the real doctoring, where I might say, you know, you flared because you stopped your Plaquenil. That's the time to re-emphasize the importance of staying on medicines and all the rest. It's very difficult to do that when someone is feeling terrible and they're in a rheumatoid flare, for instance. So it's very important, and patients do seem to understand it. When I put forward this cash price arrangement for my Medicare patients, I realized that the Medicare patient was being overtly penalized for seeing an opt-out doctor. They don't have a remedy for going as we all do. If we see an out-of-network doctor, we can show our, we can tell and get something back from our insurance company. The Medicare patient pays 100% out of their pocket, because if Medicare doesn't pay, of course, then the secondary doesn't pay. And so that's another reason to try to keep your prices as low and as fair as you can. But when I realized that this was an issue, I went ahead and brought a resolution to the Florida Medical Association. Now, I realize that's a state issue, but what I was looking for was that the FMA would support a change in federal policy. And I have the full resolution in your packet, but this basically does discuss the fact that the Medicare patient is penalized and that we need a remedy, and so it did pass. One other thing I want to mention is that I did bring before the Florida Medical Association 4 separate maintenance of certification resolutions, and I have made those in a format for Jeremy. He has them. All you have to do is ask Jeremy for them, substitute your name and your medical society, and they are ready to go, because it's very important that we get this done at our state societies. So I'm going to end with this concept, a concept of dormancy. I think there are a lot of physicians out there that are in a dormant state. I know I was for many years. It took me most of my 30 years to become active and to be what I would call a defender of the profession. There's 2 types of dormancy. There's predictive dormancy and there's consequential dormancy. The consequential dormancy is where you don't go dormant until after the adverse conditions have begun. And I think there are a lot of physicians out there who are in what I'm going to call a consequential dormancy. I know I was for my many, many years. And I think that, you know, we need to try to bring those doctors out of their dormancy. And I do believe that the opt-out message is a way to bring some of those doctors, but not everybody is ripe for that. I mean, when you think of adverse conditions, what are those adverse conditions that we are all facing that put us all into this dormant state? Well, it would be MACRA, MIPS, ICD-10, MOC, you know, I could go on. So I do think there are a couple of groups that are very ripe for this message of opt-out, and one would be the younger doctor. So this would be another post that was up, and it was Dr. Kevin Foe, and I know everybody's heard of him, and he basically posted, let's stop telling younger doctors, younger generations not to become doctors, and I couldn't agree with him more. We should be telling younger generations, go into medicine. It's an amazing field. We should be saying that to our younger doctors. However, we do need to tell them that the best way to opt out is to never opt in. And talk to them about examples of, say, direct primary care. So it's not about discouraging doctors from going into medicine. It's about discouraging doctors from going into the Medicare and the third parties. The other doctor that I think is very ripe for this message is the experienced physician, as I'll call them. So these are doctors who might be in their early 60s who love medicine, they have loved medicine, they've kept up. Their whole identity and persona is in being a doctor. And yet they're being forced out by these adverse conditions, and they're about to go into the ultimate consequential dormancy, which is to retire. And we need them. We need these doctors to stay in practice. We need them to consider opting out, to offer fair cash prices, and to promote privacy and access. And I believe these doctors, particularly this group, could really help us go a long way to saving the private practice of medicine, because they, by definition, would be in private practice. And so I really try to encourage the doctors that I know that are considering retirement. You know, there is another way. You don't have to retire to get away from these adverse conditions. There are other ways. So I'm just going to end here by saying one of my last tweets or recent tweets was that, you know, the time is now. We're going to repeal Obamacare, ditch the EHR, very important, scrap MACRA, learn the joys of opt-out magic. I really do believe opt-out has a lot of magical qualities, because you're not under those perverse incentives and torturous regulations any longer. It's really an awesome way to practice medicine. And then lastly, but maybe even more importantly, all doctors need to be proudly boycotting MOC. So I'm hoping that that message will help a lot of doctors to come out of their dormancy and to get more active. So thank you for your attention.